So I just want to touch the topic on of glaucoma. Am I not seeing my slides? Okay. So just labeled it a real malignant glaucoma. And Anna and I, we kind of prepared this talk together. We say, but we know tumors can cause glaucoma. We see that all the time. But don't forget, in glaucoma clinic, once in a while they see a patient that has an underlying tumor. So glaucoma can also be caused by tumors. That's just the other way to think about it. And of course, the treatment is rather complex. You have to think about individual patient, what kind of tumor, and also think about the comorbidities that the patient may have because of the tumor. So let's kind of touch upon some of the key components. So glaucoma, we say, at least in this setting, we don't really look for visual field defects, okay? Why is it going forward by itself? And it can happen due to benign or malignant tumors, even in metastasis. It can be present initially, concomitantly, could be a sequelae or iatrogenic from a treatment like radiation, for example, or steroids. Depends upon the type of the tumor, the location of the tumor, and the size of the tumor. We understand that in broad terms. It can be of open angle, closed angle, or neovascular type. I think this is very important. Glaucoma can lead to diagnosis of tumors, but not also just that, can be prognostic, at least in management of some tumors. We'll talk about some examples. General treatment, like in glaucoma, start with topical treatment and think about minimal invasive procedures. And in aggressive glaucoma, when the tumor is controlled, you can think about tube procedure. And MIGS are generally preferred, but you need to have really evidence of regressed tumor, and you really are concerned about extraocular extension. Let's look at some of the aspects or nuances of this. So when you have patient with tumor and glaucoma, it's not just two things, 1 + 1, there's more. You have certain problems such as dry eye from chemotherapy drops or radiation that patient had, so you need to take care of that. Patient may have conjunctival scarring, so you say, I can't really use a trabeculectomy here. Patient may have synechia or issues of the iris, and you say, I need to deal with that. Patient may have concomitant cataract, so you have to take care of that. Patient may have radiation optic neuropathy and retinopathy that kind of reduces the risk of good vision potential there. And of course, you always worry about creating more trouble than what patient already has, the risk of extraocular extension from the procedure. And always keep in mind that some patients may have shortened life expectancies, such as melanoma, so you really have to think about that also when you're offering your treatment. So let's look at some of the examples. So we say, here's a patient with ciliary body melanoma and has angle extension. You can see a seeding in the angle. This patient has glaucoma. So if the patient has 360 pigment deposition, is melanoma, you think of enucleation as the treatment. Always have to look for pigmentation in the angle, so gonioscopic is essential, and you can see a lot of pigment here, even on the anterior lens capsule. So this is not pigment dispersion glaucoma. That's all just melanoma cells everywhere. So this eye, because of this glaucoma with melanoma, would be enucleation. So glaucoma is prognostic, okay? It's taking you to enucleation. And in some cases, if you just don't dilate like Ruben just mentioned, you're going to miss an underlying tumor that's at the back. Just look at the acquired heterochromia that's on the surface. This is a patient with neovascular glaucoma. Patient had treatment with plaque therapy some months ago and now has iris rubeosis and high pressure. You say, well, how do you manage this case? Well, it depends upon how the tumor is doing, what the vision potential is, and is there any risk of metastasis here to the patient. Let's say, for example, this tumor is well regressed, it's on ultrasonographic measurements, is more than a year from the treatment, the vision potential is expected to be better, and there are no other complications, there's no vitreous hemorrhage, for example, and he doesn't have any metastasis. You say, okay, I want to save this eye because there's some vision potential. You'll do anti-VEGF injections, you'll do PRP, and think of tube when that is settled. That's one way to deal with this. Alternatively, if the tumor is regressed, but the vision is hand motions, there is vitreous hemorrhage, the patient may be starting to get mets, you say, no, really, I can't be doing tube or trab or anything. I just want to do something palliative, give some steroids, dilating drops, maybe CPC if that doesn't work. So all of it depends upon how you're managing the glaucoma, depends on what else is happening to the patient. We talked about after radiation, it's not always neovascular complications. You can have what's called melanomelitic glaucoma, which is pigment-laden macrophages, many times leading to enucleation. Example here, regressed melanoma with a lot of macrophages laden with pigment in the angle causing secondary angle closure glaucoma. Okay, this is not my case. This has been borrowed. We talked about neovascular glaucoma in the setting of retinoblastoma. In my mind, if there is neovascular glaucoma and retinoblastoma, enucleation is the treatment. And not only just that, for example here, we showed this case earlier, the eyes has to be enucleated, but we also know this is a marker for high-risk pathology, right? So we know, at least in India, for example, we say maybe 50% of such eyes will have high-risk pathology. Not so much in other parts of the world, but that's a marker for, of course, high-risk pathology and need for adjuvant therapy. So glaucoma here is prognostic for ocular survival and even the patient's own survival. So it alerts you to look into the high-risk pathology as shown here. We also know in pediatric cases, neovascular glaucoma is classic finding of medullary epithelioma. So if you see neovascular glaucoma in a child and you can't find the tumor, you don't know the cause for it, well, you have to look in ciliary body. And you'll only look at ciliary body if you do UBM. So if you have neovascular glaucoma in a child, you really must rule out medullary epithelioma. It's a classic finding. You must do UBM. And we know that such cases are overlooked. They have this, that, and the other, and medulla is missed for many years, for example. Here's a case that Seda presented, was a melanocytoma. So not everything that's dark and pigmented is a melanoma. Remember, in a smaller tumor with glaucoma, think of melanocytoma. For melanoma to cause secondary glaucoma, it usually is a large tumor. Here the tumor was only a few millimeters in size. So that kind of triggers you to think, oh, it's not a melanoma. A 3 millimeter melanoma is not going to cause secondary glaucoma. Keep that in mind. So when you're seeing small melanoma causing glaucoma, think of melanocytoma. So just little clues that you learned over time from your clinical practice. Here's a patient with neovascular glaucoma, where then mass with inflammation is a metastasis, is proven by biopsy, was it from a renal carcinoma. So we know metastasis can cause inflammation and it can also cause neovascular glaucoma. And this patient had plaque and intracameral Avastin. Here's a patient with a very subtle iris melanoma, but presented with secondary glaucoma. The melanoma really is not visible. You can do iris fluorescein, you can do OCT, and you start to see little shades of melanoma. It's a diffuse tapioca melanoma of the iris. That melanoma is translucent. We did the biopsy, had proton radiation, and eventually required a tube. This patient is out for 15 years, but this is after very years of stability. When you're feeling comfortable, then he had tube. Here's the last patient. I want to show you a patient with a lymphoma. This patient had unilateral, uncontrolled, open-angle glaucoma and was to be considered for trabeculectomy. That's the time somebody lifted the lid because they're looking at the superior area to think where to do the trab, and they find this kind of orange mass. That obviously was suspected of lymphoma. He actually also had uveal lymphoma, had ICG, ultrasound, etc. We gave him radiation, and lymphoma went away, and so did the glaucoma. So glaucoma was due to episcleral venous blockage, we think, and once we took care of that, his glaucoma settled. So just very briefly, if it's a mild glaucoma, less than 30, you can think of topical treatments. If a little bit more, you may have to use oral Damox. Things like Icostab, mannitol, Damox, IV are really not very useful. If it's preferable to do minimally invasive procedures because most of the glaucoma is due to blockage in the trabecular meshwork. So these kind of goniotomy-based procedures are very useful. We'll skip that part. Think about if it's more advanced disease, you think of tubes, not so much of trab because with photocoagulation the vision is poor, but not so much trab because there's inflammatory environment, risk of conjunctival scarring. So coming back to the glaucoma and tumor, it's not, just remember, glaucoma influences management of tumor, like in medullary, retinoblastoma, melanocytoma, and the presence of tumor influences glaucoma management. So overall, you have to prioritize the management of tumor first, obviously, and then optimize the glaucoma treatment. Thank you very much.